So we're going to start today with anatomy and physiology of the GI tract. Now, of course, this is a very big topic, but we're going to narrow it down because we're going to focus on elements of GI tract anatomy and physiology that will be particularly relevant to you in caring for patients who have colostomies, ileostomies, jejunostomies, or bowel fistulas. So let's start by looking at the GI tract kind of from a big picture perspective. There's really two components to the GI tract. The first component is the alimentary canal, which is a very long tube that starts at your mouth and ends at the anus. My brother-in-law calls this very irreverently the food and poop chute. But that's an accurate analogy because food goes in at the top and poop comes out at the bottom. You can divide that alimentary canal into the upper GI tract and the lower GI tract, and we frequently do use this terminology. So the upper GI tract is involved in ingestion, digestion, and absorption of nutrients, and it involves the mouth, the esophagus, the stomach, and the small intestine. The lower GI tract is involved in storage and elimination of waste, and that's the colon, the rectum, and the anal canal. And we'll talk about each of these in more detail. So the first element of the GI tract, alimentary canal. Then there are the accessory organs. And the accessory organs are organs outside that tube that contribute to ingestion and digestion of nutrients. It includes things like the salivary glands, the pancreas, the liver, the gallbladder. We'll talk very briefly about those. We've already said the key functions of the GI tract can be divided into the functions of the upper GI tract and lower GI tract. So first, intake, digestion, absorption of nutrients, and then secondly, storage and elimination of waste. Looking at the anatomy of the bowel, if you look at the bowel wall itself, there are 4 layers, and they're the same essentially throughout the entire alimentary canal. And some of those layers will be particularly important to you when you're caring for patients with stomas. So we're going to look at those layers briefly, and then we'll come back and reference some of this information again. So we're going to go from inside to out. The mucosa is the innermost layer, but that is the layer you typically see when you're taking care of an ostomy patient. And there are some characteristics of that mucosal layer that are of tremendous relevance that you'll be explaining to patients over and over again. You're going to tell them it's normal for your stoma to be red and wet. It looks a lot like the inside of your mouth because that's the way the bowel looks all the way down. So it will always be red and wet. It's also insensate, which is very surprising to patients that there's no feeling in that stoma because there are no nerve endings in the mucosal layer that are sensitive to touch or to pressure. So you want to be able to explain to a patient what they're seeing when they look at the stoma, what they should see every day, what's normal, what's not. The submucosal layer is a very important layer. We don't talk as much about it because you don't see it in a stoma. But the submucosal layer actually contains lots of nerve endings, lots of blood vessels, and the lymphatics. That's important because if you have a patient who develops a GI tract malignancy, as soon as that tumor invades through the mucosal layer into the submucosal layer, it has access to large vessels and to the lymphatic system. So it explains why metastasis can occur relatively early in tumor development. The third layer of the bowel wall is the muscle layer. And the muscle layer actually contains both longitudinal fibers and circular fibers. So there's 2 muscle layers in the bowel wall. I think you can see this here. Those muscle layers are very important because they contribute both to the mixing motions that promote digestion and absorption of nutrients. So you can get this back and forth where this section contracts and this relaxes, and then this contracts and this relaxes, so back and forth. You can also get propulsive motions that we know as peristalsis. So with propulsive motions, this section contracts, then this section contracts, then the next section contracts. Peristalsis, of course, moves contents along the length of the bowel. So you have two muscle layers, those muscle layers very richly innervated to provide normal bowel motility. Now on the slide it mentions the impact of the parasympathetic and sympathetic nervous systems on bowel motility. Specifically, sympathetic stimulation tends to slow the gut. It reduces secretions and also reduces motility. So you see this a lot in your postoperative patients. We know that ileus is normal for the first few days after bowel surgery because surgery, anesthesia, and many of our pain medications activate the sympathetic nervous system and slow the gut. In contrast, parasympathetic innervation increases motility. So think what happens when you give a patient Reglan. Why do we give them Reglan? To increase motility. So parasympathetic increases motility, sympathetic slows the gut. The outer layer of the bowel wall is the serosal layer. Now typically you don't see this layer, but it's an important layer because it has no mucus secreting glands and cannot keep itself moist. If you remember back to nursing school, one of the things you learned was if a patient ever eviscerates and there are exposed loops of bowel, you've got to grab sterile towels, saturate them with saline, and cover those loops of bowel to keep them viable, because the serosa cannot keep itself moist. When exposed to air, it becomes dry and inflamed and sloughs. Well, that's very important in stoma construction, because if you bring out a loop of bowel and you do not open that loop of bowel, you allow the serosa to be exposed to the air, it will become very dry, very inflamed, and you'll have a lot of bowel wall edema. So what do? They bring out the bowel, they open it, they turn it back on itself to expose the mucosal layer, which does have mucus secreting glands and can keep itself moist and viable. We'll come back to that in a later discussion when we talk about stomas that are and are not surgically matured. What I want you to remember right now is that the mucosal layer is the layer typically seen in a stoma, and that layer contains lots of mucus secreting glands, and it can keep itself moist and protected and viable. The serosal layer, no mucus secreting glands, the exposure to air causes drying and inflammation.